All right, so today I did a longer presentation that took about 1 hour on APRV, time-controlled adaptive ventilation method. So I'm going to try and speak really quickly and just get a much quicker setup and adjustment for perhaps people that are already using it. And there's a few little nuances that are worth talking about. My name is Jason. If this is your first time on the channel, I'm a respiratory therapist with 25 years experience, and I'm currently the clinical educator at the hospital that I work in. So let's jump right into the PowerPoint presentation. I'm doing these for continuing education as well for the department, and I'm going to have to learn to do quicker presentations. I tend to be long-winded and I have a big mouth. So when I think it'll take 20 minutes, I look and it's been an hour. All right, share the entire screen here. Start at the start, slideshow. Okay, so we're going to look at APRV, that stands for Airway Pressure Release Ventilation. And we're using APRV with the time-controlled adaptive ventilation method. With the TCAV method, we actually set the parameter, the P low, that we're going to talk about shortly, to 0. And what we're going to do with the time low setting is that we're going to look at the peak expiratory flow during the release phase, where we're going from P high to P low. We're going to look at the peak expiratory flow, and we're going to terminate that release when it reaches 75% of whatever that peak expiratory flow was during the release. So it's a very brief release, then we return right back up to the P high. So airway pressure release ventilation, the airway pressure part is that P high, which is a CPAP phase, which will recruit the slow recruitable compartments of the lungs. And by recruiting the alveoli, we're going to be able to recover your functional residual capacity. That way, the vent power, the stress that we're exerting on the alveolar network, if we're recruiting, the stress will be more evenly distributed over a larger surface area of alveoli. And then that stress will have less of a strain because all the alveoli are recruited. So the CPAP phase is created with the pressure high setting. We often say P high, so pressure high. So that is the high CPAP phase. And we're going to tell the ventilator how long to extend that high CPAP, that P high, which is called the time high. And after, let's say if it's 3 seconds, we're going to have the P high, that high CPAP for 3 seconds, and that will create the release. And as we get into deeper, I'm going to repeat a couple of times, we're setting the P low on the vent at 0. And what we're doing is we're terminating that release phase when it hits 75% of peak expiratory flow. For example, 100 liters per minute. It's going to descend to 75 liters per minute, and we're going to go right back up to our P high. So that T low is going to be the difference between the peak expiratory flow and the peak expiratory flow and 75% of the peak expiratory flow. So the difference in that time for that flow to descend to that level is your T low setting. That's how you're going to trap 75% of the peak expiratory flow. Because you're not allowing the flow to go to 0, meaning you're creating on purpose auto PEEP or air trapping, then we do an expiratory pause, and that is the measured P low. So though the P low is set at 0, we're purposely terminating quite briefly in the expiratory phase, the flow, and this creates a measured P low. So again, don't think of APRV as breathing on 2 CPAP levels, a high CPAP considered P high and a low CPAP considered P low. What we're actually doing is we're breathing on the P high setting, the high CPAP phase, and we're creating very brief releases. These brief releases are brief enough that you're not losing the recruitment that's occurring on your P high setting, and it's just enough of a pressure gradient to help evacuate CO2 that's accumulated in your alveoli during the P high phase. So again, APRV settings, you have P high, that is the high CPAP phase where you're doing the majority of your breathing. You have your time high, that is the time spent on this pressure high setting, that CPAP phase. You have the P low, this is the lower pressure that is measured with an expiratory pause during the release phase. And the time low is the time spent releasing from that P high as you descend, all right, towards a lower P low setting. Like I said, that is measured with an expiratory pause while your P low parameter is at 0 because we're creating air trapping purposefully. So the way you should be setting up, or the way time-controlled adaptive ventilation, APRV, when it's used with that method, should not look like this at all. There shouldn't be, breathing on a P high level and then breathing on a P low level and then back up. What we should be doing is breathing spontaneously on this P high level, and these brief releases occur to help eliminate the CO2, or they are not breathing spontaneously and they are just passively being ventilated. And even if they're passively being ventilated, when you're in that P high setting, you have oxygenation that's occurring without chest movement, but you also have diffusion of CO2 into the alveoli during that P high setting. So when you do release that ventilation, that CO2 is heavily concentrated during that release because it hasn't spent 0.7 or 0.8 inspiratory time like conventional. It's been there for 3, 4, 5 seconds perhaps, diffusing CO2 into the alveoli. So when you do get the releases, that's how CO2 is eliminated and you get more bang for your buck. That all depends on the diffusion capacity of the lung, depending on what state the lung is in. So P high settings, majority of the time we're dealing with between 20 P high setting and 30. If you were an ACVC and you're doing your protective lung ventilation, a good idea perhaps where to start with your P high setting would be the plateau before you transition. Also, for example, our vents, the pressure control is actually a peak inspiratory pressure. So if a patient's on ACPC and their compliance is really bad and we're trying higher PEEPs, we're unsuccessful at opening up collapsed areas, then it's reasonable to transition to APRV using the TCAV method wherever that peak inspiratory pressure was. And this whole peak, this whole P high is basically a mean airway pressure that is enough to reach the threshold where the alveoli start opening up. And these brief releases are brief enough that they're not allowing de-recruitment. All the work being done on the P high is not being lost. So that's the way you should be looking at this. You're exerting a P high, you're exerting the P high to the lung, and this is enough to adequately recover your functional residual capacity. And because APRV could be used passively in somebody who's not breathing at all spontaneously, but it is also a mode that encourages early spontaneous breathing on that P high level. So you want to You want to increase your functional residual capacity with this P high, improving oxygenation. It's an open lung approach. You're getting alveolar recruitment of those stubborn alveoli that perhaps it's not only about a certain pressure being exerted, it's that pressure perhaps over time that is the magic. It's not only about pressure. We know recruitment is pressure over time, and we know in conventional modes your inspiratory time is often limited 0.6 to maybe 1 second, I guess. That's why recruitment maneuvers were invented on conventional modes, because recruitment is pressure over time. But with APRV, we have that P high and that T high setting. We have that T high that can be increased seconds, 4, 5, 6, 7, 8 seconds if we wish, and that allows us to recruit much better because we're not limited in the amount of time. Also, obviously, sometimes you might be very high in your P high during the recruitment phase. Probably maybe not time for the patient to breathe, but once you want them to resume breathing, you do want the P high setting to not be so high where they have no more inspiratory capacity and the lung is just completely air trapped. You want just enough to recover the FRC and then leave room here for breathing, okay, with your inspiratory capacity. So another way of looking at this, we're trying to recover this, but still allow easy breathing with the inspiratory capacity here. If we go too aggressive with the P high, we're going to be over distending. In our intensive care, when we have some of the more tricky patients to ventilate, we'll use electrical impedance tomography, the pulmonary Vista 500. We'll do an optimal PEEP, and if we don't get what we want with conventional modes and an optimal PEEP, perhaps it's just not recruitable because it's lacking the time, then we'll keep the monitor on and we'll see how APRV, if APRV improves things. And that's kind of how APRV got initiated into our ICU, was really justifying its usage with electrical impedance tomography. As mentioned before, we're going to actually set the P low at 0. Now, the correct setting of your T low will create an intrinsic PEEP, which is your measured P low that you're going to do with an expiratory pause. So setting the P low at 0, if you're actually initiating your P low setting, what you're doing to generate a pressure low is you're closing the expiratory valve, right? You're making the diameter smaller. That creates more resistance to expiration, creates back pressure where you can get that P low or PEEP generated. Because we want that passive release to have the least amount of resistance, we just want that lung to release as quick as possible to create the best pressure gradient, which will create the best expiratory flow and the most evacuation of CO2. So, or else you're going to be expiring through the valve, the expiratory valve, with more resistance. It's going to create more back pressure. It'll slow down that passive exhalation, and that's going to give you problems with your tidal volumes during the release. It is just going to cause hypercapnia as well. So you're going to have more challenges with blood gases. So the P low needs to be set at 0 with your TCAV method. Over here is an example. You can see how low it goes, see during the release there, but you see the P low, it's set at 0 here, okay? And we have a P low at 10.6, all right? And we see over here that the flow, look how it's cut off abruptly. So it's not a normal expiratory flow that goes to baseline. You can tell that there is air trapping, and the air trapping is created by our T low. Now, I'm going to get into the discussion of something called auto release on the Jaeger V500, which basically, when I was speaking about you want to set your P low at 0, but you want to trap 75% of the peak expiratory flow on that release phase. So if it's 100 liters per minute, you're going to create a T low that stops at 75 liters per minute, and now you're back up there. Okay, so your T low is going to be what's creating the air trapping, and you have to do the measurement. We have cruise control on the Jaeger V500. It's called expiratory termination. So it is based on the flow. It is terminating the expiration from your P high to your P low, and you just set the 75. So it does it for you. But I'll show you, let's say, on an event where you want to do this method and there doesn't have the auto release or the expiratory termination, that you're going to have to freeze frame. You're going to have to go here and scroll and look at your peak expiratory flow. You're going to have to look at the timestamp. Then after, you're going to have to multiply your peak expiratory flow by 0.75 to get 75% of it. And then you're going to scroll and you're going to look at the timestamp where it hits 75. And the difference between the two timestamps is that your set T low. When you have a expiratory termination activated with auto release, you notice here the T low, it's a limit. It's a T low max. So keep that very, very high. You do not want to, let's say the vent does the calculation and says, oh, the expiratory termination at 75 is, let's say, it'll take 0.7 seconds. And that's going to be accurate to trap 75% of peak expiratory flow. But for some reason, your T low max, which is a limit, you set it to 0.4. It means that it'll try and do the calculation of 75. The actual correct T low would be, let's say, 0.7, but you went and set a T low max at 0.4. It means like I will allow you to do the calculation, but I won't allow the T low max to go more than X, whatever number. So you don't want to interfere with the auto release. So just keep the T low max well out of the way at 3-4 seconds. Here's an example of the same patient with a P low set at 0 and a measured P low with expiratory pause at 15.6. And then after, let's say, remember I told you, you don't want to activate the P low because it's going to create resistance for exhalation. So we didn't set it above the 15, but we did set it below. Maybe like I want to keep it safe, and what if something messes up? I want a backup, but what happens is it increases your P low from 15.6 to 20. And that means it's shortening your P high to P low gradient. That shortens the flow gradient, the pressure gradient, which shortens the amount of expiratory flow, and that shortens your release volumes. You're going to have trouble with your blood gases. Your T high is the amount of time on your pressure high level. The T high creates these mandatory releases, or a mandatory release rate that helps evacuate the CO2. To determine how many releases, this determines how many releases can occur in 1 minute. So if you already have a spontaneously breathing patient, you can set a pretty extended time high, 4, 5, 6 seconds. If the patient is not breathing yet, they're in ICU, maybe they're acidotic, you're going to have to start with a much lower time high. You're going to have these CPAP phases are going to be short initially. You want to create a lot of releases, almost like a mandatory rest rate to blow off the CO2 initially. So short T high creates in a way a higher mandatory rest rate, or higher releases, number of releases. This helps to ventilate the CO2 mechanically from the patient. It's kind of going to start looking a lot more like ACPC and not the classical high C, long prolonged CPAP phase. So it looks like ACPC with a very short T high. That it looks like ACPC with air trapping, because we're still terminating at 75% of peak expiratory flow. So that's how you basically will look at your T high. Hey, I'll start low. I'm going to get, a minute ventilation that I'm comfortable with on conventional mode. Then I'll wait for a blood gas. Hey, my blood gas is normal. Hey, I'm going to stretch my T high a little bit more. You can, 0.1, 0.2, 0.5 at a time. You'll get used to using the mode. The opposite is true. You started with maybe a T high that was too long, and now you have a little bit of a respiratory acidosis. Then you're going to have to shorten your T high. So shorten your T high, creates more releases, helps mechanically ventilate the CO2. Longer T highs, less mandatory releases, less mandatory rest rate. You're relying more on CPAP and the diffusion potential of the lung. This stretched out CPAP phase of using the time high to stretch it out encourages spontaneous breathing. Just doing the math, let's say you had a T high of 5.5 and your T lows were on average 0.5. So a whole respiratory cycle, the whole cycle is 6 seconds. So, 60 divided by 6, you have about 10 releases. Then your patient, let's say, is acidotic, has a acidosis, CO2 is a little too high for your comfort. Then you're going to shorten, let's say 5.5 to 3.5, let's say. You still have a very similar T low, so that whole cycle is 4 seconds, and you divide that. Now you've increased the rate of releases from 10 to 15. So again, I've said it multiple times, but for those who are visual, T low is set to terminate at 75% of peak expiratory flow. If you're not using auto release, you'll have to freeze that waveform. You're going to have to find the peak expiratory flow. You're going to have to look at the timestamp, the time marking. Then you're going to take that peak expiratory flow, multiply it by 0.75 to get 75% of the peak expiratory flow. You're going to look at that timestamp. And the T low that you're going to set, if you don't have this auto release that they have on Draeger, is the 75% of peak expiratory flow. Take that timestamp and minus your peak expiratory flow timestamp. And the difference between those is your T low setting. You'll have to be very vigilant because your expiratory flow waveform can change between rounds. So you have to be vigilant. Again, 75%, for example, 100 liters per minute is the peak expiratory flow on the release. The natural angle of the time flow for expiration is like this. You're going to have to take your timestamp here where you have your peak expiratory flow. You multiply the 100 by 0.75. That means 75 liters per minute here. And you take your difference, and that's going to be your time low. And this is what creates, by trapping 75% of peak expiratory flow, that's where you're getting the most stable alveolar network. This I just did as an example for math. Let's say at 100 liters per minute, the timestamp was 11.25. And then at 75 liters per minute, after doing the math of 0.75 times the 100, I get 11.65. Then I subtract the 11.65 from the 11.25. It gives me 0.4. That is my T low setting that will trap 75% of the peak expiratory flow, which will create a stable alveoli that will hopefully, will not collapse. At least this is the best chance of it not collapsing, is when it's at 75. You see, this is a pig lung model, and you see they allow it the peak expiratory flow to descend to 10, and you can see a lot of atelectasis here. 25 as well, 50, even just allowing it to empty halfway, you're already losing alveoli. They're snapping open and closed between inspiration and expiration. But with 75% you're still allowed, it's like the money spot, it's the gold spot, where it seems to do a great job at evacuating CO2 and keeping your alveoli the same diameter between inspiration and expiration. So that's the auto release that we activate here. It's very well done. So over here, just realize that one other parameter that can help you with tidal volumes is the slope. So when you're applying the vent power, so the vent power, let's say this is 28. 28 is exerted. The lung starts slowly inflating behind. Then all of a sudden during the release, the lung doesn't go right away. It's the release. So the pressure is released and the lung here starts slowly following. And then before it can get anywhere, to a really low pressure level in the lung, you're already bouncing back. And so this is kind of the viscoelastic property of the lung, where you have a certain amount of energy or power being exerted and the lung follows shortly behind, and then that power, let's say, is released, and then the lung slowly follows behind the release of that pressure. So it's not following, immediately. Now, the slope adjustment on the vent deals with the P low and returning to your P high. So when you have a slope, let's say at 0, it'll go down and it'll return really fast. So this viscoelastic property of the lung, if you have a slope at 0 and then you compare, let's say, to 0.2 seconds, so here's 0, bounces up fast. Here's a slope of 0.2 or 20%. It goes like this, and then it slowly ramps up a little bit compared to the 0. So because it's not popping up as fast to your P high setting, it's allowing the gradient to be a little bit larger. It's allowing for just a little bit more emptying. So your P low might be a little bit lower. Your T high might be just a little bit longer, creates a bigger release gradient, and that helps with the tidal volume. So because you don't want to start playing with a 75, where you start the patient on APRV, 75, I'm stopping the release at 75. The volumes are so small. Maybe I should let it empty to 50 because I'll get a bigger gradient. Yeah, but you're going to be de-recruiting on the release phase. Never touch the 75. Keep the 75 always as is. You can start with a slope of 0.2. And as you increase your tidal volumes, then after you can play with the slope and reduce it by 0.5 at a time. And you're going to see 0.2 of a slope, larger tidal volumes, no slope, smaller tidal volumes. And this just has to do with the subtle changes that the slope has with the pressure gradient, how quick we pop back up to the P high setting. So for the weaning of this, it's very simple. You're going to, as the condition of the lung and the compliance it improves, the status of the lung improves, just like pressure control or pressure support, you're going to need less and less pressure to generate a certain amount of tidal volume. Same thing applies here. The lung's improving, so your volumes are going to start getting better, bigger with that P high setting. So you can start reducing the P high as volumes start reaching, often 12 mLs per kilogram is what we tolerate during the release. Lets us know our lung is likely fully recruited. If you're hitting 12, then it's time to start weaning your P high. If you're in a situation where you can't wean for some reason the P high, maybe the patient's like 6 liters fluid positive or something like that, then and you're concerned about the larger tidal volumes during the release and your blood gases are good and you have room to move, then you can, without touching your P high, you can just shorten your slope. By shortening the slope, you're going to reduce those release tidal volumes, and if that's a concern, you can use it that way. Often, if we are on APRV, try and get to maybe a P high of 16 with a stretch of 6, 7, or 8 seconds, and then transition to pressure support if you like. If you're uncomfortable extubating on APRV, you can match the mean pressure closely if you're around P high of 16, stretched out to 6, 7, or 8 seconds. You're going to be able to transition with a PEEP. Just add a little bit of a PEEP. Often what I'll do is whatever my P low was prior to switching to pressure support, I just put my PEEP where my P low was. So one of the cool things with the P high is, let's say if you're at 25%, you're at 25 centimeters of H2O, you're stretched out with 4 seconds, and the initial average during the releases is 375. Then an hour later, it's 350. Then 2 hours later, it's 450. Then 8 hours, it's 650. And then 2 shifts later, it's 750, and it stays at this amount. If your P high has been constant, okay, and your release volumes are getting bigger and bigger, it means that you're recruiting functional residual capacity. It means that you have a lot more of the lung recruited. And that's why when the lung is fully recruited, it tends to be around 12 mLs per kilogram. So are we concerned about the occasional VTs that hit like 10 to 12 mLs per kilogram during the release? So the recruitment of the lung compartments with different time constants occur because APRV's ability to extend time. All right, so we're recruiting a lot more, and by having a lot more recruited alveoli, we're actually reducing the stress, how it is distributed over a larger surface area of alveoli, and then that stress that exerts a change in shape, volumetric changes in shape. If you have all the alveoli taking part in dealing with that volume, you're going to have less strain. So less strain and stress and strain on your lung. So the VT delivered to the lung versus VT delivered to the alveoli. Think of it this way: if you have 6 cc's per kilogram, but half of your recruited, the alveoli that are taking part in dealing with those 6 cc's per kilogram of ideal body weight, do they really feel like it's 6 mLs per kilogram? Or are they dealing with, because half of the alveoli didn't show up to work, the stress and strain is like 12 cc's per kilogram. And then within the ones that are taking part in the work, there's also varying time constants. There's differences in how quickly they'll open up. So some of the most compliant areas and healthy areas will likely get more than 12. They might get 14 to 16. So starting to think about stress and strain in protective lung ventilation is very important. More alveoli surface area reduces the stress of each individual alveoli. You also have in APRV that collateral alveolar ventilation through the connecting channels, the Martin's channel, Lambert, and the pore of Cons. And these only happen once, gas flow is no longer moving, right? And then the pendulum effect can be activated. So usually during conventional ventilation, very little communications are occurring between these communicating channels within the alveolar units, because it's just too short. It's like 0.7 seconds before you know it, we're expiring, and then the next breath is coming in. But you do have the capacity for collateral alveolar ventilation with APRV. There's also something called alveolar interdependence. Once your alveoli is derecruited, the healthy alveoli no longer has the wall of the adjacent alveoli to kind of support it. So that as well will lead to more strain on the alveoli and possible like distortions in the natural shape of the alveoli, because they don't have the neighbors that are kind of supporting the adjacent walls. So recruited alveoli, the more you recruit, the more you're going to reduce the strain, while obviously collapsed alveoli increase strain. And that's why this study here, prevention and treatment of acute lung injury with time-controlled adaptive ventilation, looking at this here, we have during the release phases, 12 mLs per kilogram of ideal body weight happening. This is the ARDSNet using low tidal volume ventilation, and we can see the lung injury here as opposed to a pretty pristine lung. Definitely no sign of ventilator-induced lung injury, while the ARDSNet with the lower tidal volume is heavily damaged. Why? Because it's not all about tidal volume. It's about how much tidal. Yeah, come on in. 20 minutes?
I think so.
All right, I'm almost done. So yeah, the 6 cc's per kilogram right here, okay? And then you have 12 cc's per kilogram right there.
Okay.
The thing is that this one's FRC was totally de-recruited. So as far as the alveoli are concerned, they feel like it could be 12, 16 or whatever. So this is important because people are concerned about the 12 cc's.
Yes.
And this study specifically deals with the 12 mLs per kilogram right there. All right, so that's the end of it.
Perfect.
Let's see how much time it took. Okay, 36 minutes was acceptable.
Yeah.
So you see the second time around,
Yeah,
it went
that's it.
faster. I'll get out of your hair.
Just save everything. I don't want you to.
It's saved in the
Oh,
library.
perfect. That's perfect.